Schizophrenia literally means split mind. However, this can be confusing, and the term schizophrenia is widely misused. Some people use it to refer to multiple personality disorder, which is incorrect. The split in schizophrenia is a split from reality, and it is marked by psychosis. The split is between emotions and thinking, rather than between personalities. Schizophrenia disorders represent a spectrum of disorders marked by disturbances in thought that spill over to affect perceptual, social, and emotional processes. Disordered thinking is evidenced by ideas that are not logically related, faulty perception and attention, a lack of emotional expressiveness, or at times inappropriate expressions, and disturbances in movement and behavior, such as a disheveled appearance. People with schizophrenia may withdraw from other people and from everyday reality, often into a life of odd beliefs and hallucinations. Given that schizophrenia is associated with such widespread disruptions in a person's life, it has been difficult to uncover the causes of the disorder and develop effective methods to treat it. We still have a long way to go before we fully understand the multiple factors that trigger schizophrenia and have treatments that are both effective and free of unpleasant side effects. The symptoms of schizophrenia invade every aspect of a person, the way someone thinks, feels, and behaves. Not surprisingly, then, these symptoms can interfere with maintaining stable employment, living independently, and having close relationships with other people. They can also provoke ridicule and persecution from other people. Substance abuse rates are high, perhaps reflecting an attempt to achieve some relief from symptoms. On top of this grim picture, the suicide rate among people with schizophrenia is high. Indeed, people with schizophrenia are 12 times more likely to die of suicide than people in the general population. Not only are individuals with schizophrenia more likely to die from suicide than those in the general population, they are also more likely to die from any cause. The lifetime prevalence of schizophrenia is around 1%, and it affects men slightly more often than women. Schizophrenia is diagnosed more frequently among some groups, such as African Americans, though it remains unclear whether this reflects an actual difference among groups or bias among clinicians. Schizophrenia sometimes begins in childhood, but it usually appears in late adolescence or early adulthood, and somewhat earlier in men than in women. People with schizophrenia typically have a number of acute episodes of their symptoms and less severe but still debilitating symptoms between episodes. The range of symptoms in the diagnosis of schizophrenia is extensive, although people with schizophrenia typically have only some of these problems at any given time. Thus, people with schizophrenia can differ from one another quite a bit.
Schizophrenia itself is just one of the diagnoses on the spectrum, and it falls on the severe end of the spectrum. It is a serious chronic mental illness. Research suggests schizophrenia as a diagnosis is not distinct, but actually one of a group of disorders with similar features. The disorders on the spectrum share similar symptoms involving psychosis, a condition involving a loss of contact with or a distorted view of reality, also unusual or disorganized motor behavior, and uncommon or inappropriate behaviors affecting social interactions. Schizophrenia spectrum disorders are difficult to treat successfully when they occur alone, but when there is substance abuse as well, patients frequently get worse and do not respond to treatment. A large-scale study found the prevalence of an alcohol use disorder diagnosis in the schizophrenic population was 33% compared to 13.5% in the general population. Most believe this happens because those who experience auditory hallucinations and anxiety self-medicate, and treatment for these dual disorders is not coordinated. Most communities treat schizophrenic and substance use disorders separately. Also, once dually diagnosed, these patients receive less outpatient care. since mental health workers see them as less desirable and more difficult to treat. A main objective of this unit is to familiarize you with the symptoms of the schizophrenia spectrum disorders, which fall into 4 categories: positive symptoms, cognitive symptoms, psychomotor abnormalities, and negative symptoms. Starting with the positive symptoms, think of the positive symptoms as adding something that shouldn't be there or something that normally wouldn't be there. Positive symptoms include delusions, hallucinations, disordered thinking, incoherent communication, and bizarre behavior. On the spectrum, these symptoms range in severity and may persist or fluctuate. There can also be poor insight, which refers to an inability to recognize these symptoms as abnormal. The DSM-5 uses a fancy term, a fancy clinical term, anosognosia, to refer to this lack of insight. The problem with lack of insight is there is poor reality testing, and there is a split from reality. Psychotic symptoms are so real to the patient that they are not recognized as symptoms. And we'll be looking at these symptoms a little more closely. This graph shows that many individuals with schizophrenia are unaware that they have signs and symptoms of a mental illness. Most are unaware of asociality, which is little interest in social relationships. And this may be due to preoccupation with delusions and hallucinations. A psychotic episode is a very frightening and confusing experience and damages a person's sense of control and confidence.
Quite simply, delusions are false personal beliefs. What makes them delusions is that they are fixed. You can't use logic to talk someone out of a delusion. I have supervised many frustrated therapists who have tried and tried. No doubt all of us at one time or another have been concerned because we believed that others thought badly of us. And some of the time this belief may have been justified. Consider, though, the anguish you would feel if you were firmly convinced that many people did not like you. Indeed, that they disliked you so much that they were plotting against you. Imagine that your persecutors have sophisticated listening devices that let them tune in on your most private conversations and gather evidence in a plot to discredit you. Those around you, including your loved ones, are unable to reassure you that people are not spying on you. Even your closest friends are gradually joining forces with your tormentor. Anxious and angry, you begin taking counteractions against the persecutors. You carefully check any new room you enter for listening devices. When you meet people for the first time, you question them at great length to determine whether they are part of the plot against you. Such delusions, which are beliefs contrary to reality and firmly held in spite of disconfirming evidence, are common positive symptoms of schizophrenia. Persecutory delusions, such as those I just described, were found in 65% of a large cross-national sample of people diagnosed with schizophrenia. Delusions may take on several other forms as well, including the following. A person may believe that thoughts that are not his or her own have been placed in his or her mind by an external source. This is called thought insertion. For example, a woman may believe that the government has inserted a computer chip in her brain so that thoughts can be inserted into her head. A person may believe that his or her thoughts are being broadcast or transmitted so that others know what he or she is thinking. This is called thought broadcasting. When walking down the street, a man may look suspiciously at passers-by, thinking that they are able to hear what he is thinking, even though he is not saying anything out loud. A person may believe that an external force controls his or her feelings or behaviors. For example, a person may believe that his or her behavior is being controlled by the signals emitted from cell phone towers. A person may have grandiose delusions, an exaggerated sense of his or her own importance, power, knowledge, or identity. For example, a woman may believe that she can cause the wind to change direction just by moving her hands. person may have ideas of reference, incorporating unimportant events with a delusional framework, and reading personal significance into the trivial activities of others. For instance, people with this symptom might think that overheard segments of conversations are about them, and that the frequent appearance of the same person on a street where they customarily walk means that they are being watched, and that they see on and what they see on television or read in magazines somehow refers specifically to them. Now, although delusions are found among more than half of the people with schizophrenia, they are also found among those with other diagnoses, such as bipolar disorder, depression with psychotic features, and delusional disorder.
Hallucinations are perceptions of non-existent or absent stimuli, and they involve the senses. Auditory, which is the most common type of hallucination. People may hear male or female voices, which may be innocuous or threatening. The voices may give commands to hurt oneself or others. Other senses that can be involved in hallucinations are visual, olfactory, tactile, and gustatory. I recall a client who smelled gasoline, and this led to paranoid ideation that someone was trying to burn down his house. Uh, these hallucinatory experiences are very real to the person. Remember, our senses operate by transmitting nerve impulses to the brain, and certain regions of the brain will interpret this information to tell us what is in our environment. Now, because the brain regions are not working properly in schizophrenia or are internally activated, a person may actually see things that are not there. Individuals then respond to this internal stimuli as if it were real. Now, you may have seen people talking to or even arguing with the voices in their head. The second category of symptoms in schizophrenia spectrum disorders are cognitive. Cognitive symptoms appear as disorganized thinking, communication, and speech, and are common characteristics of schizophrenia. They may become apparent in speech through something called word salad, where there is a random mixture of words and phrases. For example, someone might say, "Colorless green ideas sleep furiously." Speech can obviously become quite confusing. There may also be loosening of associations, also called cognitive slippage. This is a continual shifting from topic to topic without apparent logical or meaningful connection between thoughts. Cognitive symptoms are often present before the first psychotic episode, and they tend to persist even with treatment. The third category of symptoms of schizophrenia spectrum disorders include grossly disorganized or abnormal psychomotor behavior. This refers to body movements or posture. Catatonia can be either excited or withdrawn and represents extremes in activity level. Excited catatonia can be agitation or very hyperactive behavior. On the other hand, catatonia can be withdrawn. Individuals may be totally unresponsive and hold strange positions for long periods of time. The fourth category of symptoms include negative symptoms, a decreased ability to initiate actions or speech, express emotions, or feel pleasure. These are symptoms that take away something, and there are some clinical terms that are used for these. Avolition, the inability to take action or become goal-oriented. Alogia, a lack of meaningful speech. Asociality, minimal interest in social relationships. And anhedonia, a reduced ability to experience pleasure. Anhedonia is also a symptom and a term used to describe a symptom of depression. Mental health professionals use these terms in assessments and progress notes, so they are important to remember. Another negative symptom is diminished emotional expression. This is also called restricted affect or flattened affect. Approximately 15 to 25% of individuals with schizophrenia display primarily negative symptoms. According to the DSM-5, a diagnosis of schizophrenia requires at least two of the following symptoms: delusions, hallucinations, disorganized speech, gross motor disturbance, negative symptoms. Now, at least one of the two indicators must be delusions, hallucinations, or disorganized speech. Also, there must be evidence of a deterioration from a previous level of functioning. The symptoms for schizophrenia as a diagnosis must be present most of the time for at least a month, and the disturbance must persist for at least 6 months. Schizophrenia has been observed and described as occurring in phases. Sudden onset can occur, but in most cases it starts with a prodromal phase. There is a gradual onset and buildup of symptoms, such as social withdrawal and isolation, inappropriate affect, such as laughing at a sad story or laughing at a funeral. Poor communication patterns begin occurring, and there is obvious neglect of personal grooming and hygiene. In the active phase, symptoms are prominent and there are full-blown symptoms. In the residual phase, symptom severity declines and the presentation may look like it did in the prodromal phase. There is less impairment, but complete recovery from schizophrenia is rare.
The DSM-5 criteria for schizophrenia differ in some ways from the DSM-4 TR criteria. Like the DSM-4 TR, the DSM-5 requires that the symptoms last for at least 6 months for the diagnosis. The 6-month period must include at least 1 month of an acute episode or active phase. The remaining time required for the diagnosis can occur either before the active phase or after the active phase. This time criterion eliminates people who have a brief psychotic episode and then recover quickly. The DSM-5 removed the subtypes of schizophrenia that were part of the DSM-4 TR: paranoid, disorganized, catatonic, and undifferentiated. Now, I mention these subtypes simply because you may see them in some records that you come across. The reason they were removed is due to their questionable usefulness, poor reliability, considerable overlap between the subtypes, and poor predictive validity. That is, the diagnosis of one type or another type of schizophrenia provided little information that was helpful in either treating the disorder or predicting its course. Schizophrenia is part of the DSM-5 chapter entitled Schizophrenia Spectrum and Other Psychotic Disorders, and there are a number of other disorders in this group. Two brief psychotic disorders are schizophreniform disorder and brief psychotic disorder. The symptoms of schizophreniform disorder are the same as those of schizophrenia, but last only from 1 to 6 months. Brief psychotic disorder lasts from 1 day to 1 month and is often brought on by extreme stress. These two disorders had one change in DSM-5. The symptoms must include hallucinations, delusions, or disorganized speech. Schizoaffective disorder comprises a mixture of symptoms of schizophrenia and mood disorders. The DSM-5 requires either a depressive or manic episode rather than simply mood disorder symptoms, as was done in the DSM-4 TR. A person with delusional disorder is troubled by persistent delusions of persecution or by delusional jealousy, the unfounded conviction that a spouse or lover is unfaithful. Other delusions seen in this disorder include delusions of being followed, delusions of erotomania, believing that one is loved by some other person, usually a complete stranger with a higher social status, and delusions of having a general medical condition, such as having cancer. This category had one change in the DSM-5. Delusions are no longer required to be non-bizarre. The DSM-5 added a new category to the conditions for further study. part of section 3, called attenuated psychosis syndrome. The idea for this syndrome came from research over the past 2 decades that has sought to identify young people who are at risk for developing schizophrenia. These types of studies, called clinical high-risk studies, and the starting point for these prospective longitudinal studies is the reliable identification of youth who present with mild positive symptoms that might later develop into schizophrenia.
If we can take a broader perspective for just a moment, schizophrenia is as much a social problem as it is a psychological one. Consider the financial costs of hospitalization, treatment, and loss of productivity, estimated at $62.7 billion annually. The newer antipsychotic medications are quite expensive. There is a lifetime prevalence rate in the United States of 1.1%. And the revolution in antipsychotic medication has helped people to function well enough to be discharged quickly. The problem is that adequate support for these folks is not available. A frequent consequence is the revolving door syndrome of treatment and relapse. Schizophrenia usually emerges during adolescence or early adulthood, and its course is variable with three likely outcomes. Patients with milder versions who experience a full recovery, patients who experience a partial recovery and who are in and out of treatment facilities, and patients whose symptoms are persistent and severe and who require permanent hospitalization. The outlook for individuals diagnosed with schizophrenia is brightening. Improvements in psychotherapy and medication have led to increased optimism regarding the course of this disorder. Some follow-up studies provide reasons for this optimism. Data showed us that after 10 years, a majority improved over time, and a minority deteriorated. A 15-year study showed 40% had periods of substantial recovery, and a sizable minority were not on any medication. There is a new perspective provided through the recovery model, which focuses on the possibility of getting better and having a meaningful life. The biological dimension has focused on genetics and heredity as playing an important role. We now understand that there are interactions among a large number of different genes rather than just a specific gene underlying etiology. Also, we know that closer blood relatives have a greater risk of developing the disorder. The lifetime risk or concordance rate of developing schizophrenia is strongly correlated with the degree of genetic influence. This chart showing concordance rates is based on pooled data from 40 studies. Although environment also plays a role, this data suggests there must be a genetic vulnerability to this disorder. You can see the lifetime risk is higher for identical twins than for fraternal twins, and risk decreases as genetic relatedness decreases. Even with 100% genetic relatedness, the concordance rate is less than 50%. It's not 100%, indicating that environment plays an important role. Researchers are moving away from concordance rates and focusing now on the genes responsible for the characteristics or specific traits that show up in this disorder. So they are identifying something called endophenotypes, which exist in a person before the onset of the disorder. They've identified some possible endophenotypes, which include irregularities in working memory, executive function, sustained attention, and verbal memory. These measurable heritable traits are clues to the genetics underlying this disorder. Schizophrenia is heritable, and endophenotypes may shed a light on the hidden genetic mechanisms of this disorder. Scientists are also looking at neurostructures for clues about the etiology of schizophrenia. What they have found is individuals with schizophrenia have decreased volume in the cortex and ventricle enlargements. They've also found rapid loss of brain cells over a 6-year period in young people with schizophrenia. This was found by Paul Thompson of UCLA Medical Center. He's now at USC in a longitudinal study. And Thompson called this rapid loss of brain cells a forest fire in the brain. Researchers have also found ineffective communication between different brain regions, which may lead to the cognitive, negative, and positive symptoms. I just want to talk a little bit more about a particular structural abnormality in the brain. CT and MRI brain imaging scans have shown that patients with schizophrenia have enlarged brain ventricles. Ventricles are simply cavities in the brain filled with cerebrospinal fluid, and they are an important communication network, and they produce cerebrospinal fluid. It is unclear, however, whether this abnormality is the cause or the result of this disorder. Now, this is an actual MRI scan of the brains of twins, one of whom has schizophrenia and one who does not. It clearly shows the enlarged ventricles, which are thought to be a causal factor in schizophrenia. Research on biochemical influences provides some interesting clues as to the etiology of schizophrenia. In the biological dimension, the dopamine hypothesis has been supported. This hypothesis states that schizophrenia may result from excess or too much dopamine activity in certain areas of the brain. And three types of drugs have supported this idea. Phenothiazines block dopamine receptor sites and reduce symptoms. L-DOPA, which is used to treat Parkinson's disease and increases dopamine levels, sometimes produces schizophrenic-like symptoms. And amphetamines increase dopamine availability and produce symptoms similar to acute paranoid schizophrenia. Certain social factors have an influence, including maltreatment during childhood, chronic bullying, relationships within the home, and something called expressed emotion, which refers to negative communication patterns among relatives of individuals with schizophrenia. There is an important relationship between expressed emotion and relapse rates in schizophrenia. Expressed emotion, or EE, is the degree to which a relative of an individual with schizophrenia displays highly critical or emotionally over-involved attitudes toward the patient. A family's EE is a good predictor of the course of a schizophrenic's illness. Patients who return to families high in EE are 3 to 4 times more likely to relapse because they add stress. As I mentioned at the beginning, the treatment of schizophrenia is quite challenging. Treatment today typically involves antipsychotic medication combined with some type of psychosocial therapy. Also, there has been a recent shift from focusing on what's wrong with the person toward building on strengths and promoting health, independence, and self-determination. The recovery model focuses on separating the person from the illness. The idea is that you are not your illness, and treatment provides hope and empowerment. Antipsychotic medications can reduce the intensity of symptoms, such as hallucinations and delusions, but dosage levels need to be monitored, and some serious side effects can occur, which we'll look at in a moment. It's important to remember the medications manage the symptoms and do not cure the disorder. When Thorazine was introduced in 1955, it began a new era in the treatment of schizophrenia. Symptoms were drastically reduced. The first-generation antipsychotics, such as Thorazine and Haldol, are still used and are still effective treatments, and they work by reducing dopamine levels. Newer antipsychotics, called atypical antipsychotics, such as Risperdal, Seroquel, and Zyprexa, act on both dopamine and serotonin. The atypical antipsychotics are said to have fewer side effects. These newer antipsychotics are 10 times more expensive than the older ones, And there is a lack of evidence that the newer ones are any more effective than the older ones. Quite interestingly, there are ongoing concerns over medication effectiveness. Research has shown a relatively large group of people with schizophrenia do not benefit at all from antipsychotic medication. Of course, medication compliance could be an issue here. And between 50 and 75% of patients discontinue use of antipsychotics for various reasons, including side effects. Some do not believe they need antipsychotics, and some simply mistrust the physician. Medications are discontinued sometimes even by the prescribing physician due to side effects. Every medication has side effects, and there is always a need to consider the risks versus the benefits. Some side effects can be permanent, remaining even after the medication is stopped, so close monitoring is needed. Some side effects are called extrapyramidal symptoms, and they include Parkinsonism, which is muscle tremors, shakiness, and immobility; dystonia, involuntary muscle contractions in limbs and in the tongue; and akathisia, which is motor restlessness. This restlessness can be quite dramatic. I recall having a session with a client who paced in the office during the entire time. Some other side effects of antipsychotic medication include tardive dyskinesia, which is observed as involuntary and rhythmic tongue movement. The tongue darts in and out of the mouth. Now, this is a chronic condition. There can also be lip smacking and some other facial movements.